one is MRC scale for muscle strain. Another important point is distinguishing, as I said before, distinguishing between upper motor neuron and lower motor neuron. It is not exactly the same thing as central or peripheral distinguishing, because it's why I'm saying that it's not exactly the same. It's very similar, yes, but it's not exactly the same, because think of central nervous system and peripheral nervous system as a highway with lots of lines. For example, it has 4 or 5 lines to go on for different functions, for voluntary movements, for sensory movements, for reflective movements. But upper motor neuron is just one line in the whole peripheral and central nervous system structure. And another anatomical differentiation between these two entities is another thing is, for example, lower motor neuron is starting, in fact, inside the central nervous system, in the anterior horn of the spinal cord. Again, we are going on our checklist, the spinal cord. The most important part is we should not miss any level pathology in here. For example, Dr. Sema just talked about low back pain a few minutes ago, and she mentioned about, for example, spinal cord compressions. Another thing, caudo-equina syndrome. Another thing, epidural abscess, with showing themselves with low back pain, in fact. And also, they generally have, they mostly have, neurological examination findings also. Red flag is, again, another common symptom for leg pain pathologies, again. Urinary retention and incontinence in this patient. So we have to look for extra clues with the patient. Peripheral nerves, if we are talking about peripheral nerves, the lower motor neuron parts, now we go on. The ascending thread is a very, very important entity in here. For example, the most famous one, maybe we are not seeing it every day, every emergency shift, but it's a very important and famous one, Guillain-Barré syndrome. Guillain-Barré syndrome manifests itself with a prior infection, cause autoimmune reply in the body, in the human body, which results with the external parts of this destruction of external part of peripheral nerves, which is result in ascending paralysis, areflexia or hyperreflexia generally, and also autonomic dysfunction. But there is an important point in here, because there is a mimic for Guillain-Barré syndrome. It's called tick paralysis. We are not very familiar in Turkey, the tick paralysis, because we do not have this specific tick type in here in our country. But I think it's generally seen in America as a continent. It's not very, very uncommon thing for them. And this tick exogens or toxins cause very similar type of paralysis, ascending paralysis, just like Guillain-Barré. So it's very possible to not to be able to distinguish between these two entities. After the peripheral nerves, the next stop for us, remember, neuromuscular junction. And in here, generally, we are talking about fatigable patients. In neuromuscular junction pathologies, for example, like myasthenia gravis, the most famous one for here, for this setup, these patients generally use their muscles and get tired. When they are using more muscles, more often, they tired more. That's the distinguishable, that's the most important symptomatic situation for these patients. But
Excuse
again,
me,
there is
doctor,
again,
just a little reminder. You have about 3 minutes.
yeah, yes, thank you.
Thanks,
There is also another mimic for again for myasthenia gravis that's called botulism. Again, which the part that we have to be again to be a toxicologist alongside with a neurologist in the emergency department. In the botulism, the neurotransmitter is acetylcholine neurotransmitter is inhibited by the botulinum neurotoxins, and again we are encountering with a fatigable person or patient again in the ED. Our last stop is muscles, and interestingly, sometimes the problem, in fact, commonly, the problem for true muscle weakness, again, the problem is not about nerves. It just can be related with chemicals. The most important, or we have to look especially electrolytes for these muscle weaknesses, because flaccid paralysis in the emergency department is a highly encountered situation for all of us. The clinical presentation, acute flaccid paralysis, hyporeflexia, and plus recurrent episodes generally for these patients. We have to look for potassium and also calcium in these patient groups. Severe hypokalemia below 2.5 cause severe periodic paralysis in these patients. Hypokalemic periodic paralysis can be seen in 3 ways in these patients. It can be just primarily genetic or secondary to GI bleeding, for example, and thirdly, hypotoxic situations. So in these patients, we have to check their history with detail, the recurrence of the episodes, and also family history. But remember, please, they can be also sporadic as well. And of course, lab tests, especially potassium, and also please check calcium, do not forget that. And in this patient group, you have to order also, in fact, during the first diagnostic evaluation, you have to ask for thyroid function tests as well. My last slides right now, the important part, red flags for us should be sudden onset. The sudden onset should warn us about stroke or hemorrhage. If there is this respiratory distress in our weak patient, so we have to always consider or exclude Guillain-Barré syndrome, myasthenia gravis, or botulism. If you have fever and back pain, and that time, always you have to exclude epidural abscess in these patients. Non-neurovascular weakness origins, please remember and never forget, always exclude again sepsis or acute infection. It's not always should be sepsis. It can be an acute infection as well. And also maybe always see their, for example, troponin level with, of course, EKG, because they may have suffered from acute myocardial infarction. Clinical pearls for today, for stabilization for the resuscitation of unstable patients, please do not rely on, do not decide on just oxygen saturation peripheric oxygen saturation in real neuromuscular pathology patients, because the problem is ventilation in these patients, aka carbon dioxide clearance. It's not the problem, is not oxygenation part. So the only oxygen saturation do not give true information for us. So maybe what can we do in this case? In this case, we have to use pulmonary bedside pulmonary function tests. It looks a bit confusing, but it's very, very basic test, in fact. Match blowing test, just blowing the match, of course. Bitmek üzere.
Okay.
Single breath count and tracheal auscultation and goas. My last warning about an intubation phase, the hyperkalemia risk. Please always prefer rocuronium and avoid succinylcholine, because it can cause instant release of intracellular potassium release into the veins, and it can end up with cardiac arrest in these patients. And summary, clarify between weakness, malaise, and fatigue. Use anatomical approach, stabilize life rates first. Please do a fine neurological examination, because if you do not look at the tendon reflexes, if you do not ask for or check for urinary retention or incontinence, you will miss the patients. Lastly, use what tests you need, what imaging you need in all the patients. Thank you very much for listening. If any questions, I'm here.
Herkese teşekkürler. Çok güzel geçti. Bir sorusu olan var mı?
Is there any question from the audience?
In fact, it affects different parts of motor tract, but sometimes it can be confused by the physicians. It again depends on the anamnesis and physical examination findings, in fact. Of course. Thank you.
Okay, thank you very much, Professor Sevilay. Thank you very much for this nice presentation. Now, the next and the last speaker is Dr. Nazmiye. She is coming from France. And thank you very much for her supporting and assisting, encouraging us and promoting us since many years. And one of her very nice features is that, I like it very much, she always ends her speak in time, because she respects the expectation of the audience. You are welcome again, Dr. Nazmiye.
Thank you very much to invite me to talk about this topic. This topic is very important for me and for us, and it touched me to talk about this topic. The topic is carrying without burnout. Can we, in a long time, can we work in emergency department without burnout? It is the question. My opinion is, if I know my risk, I can act. And I can act to reduce, to decrease my risk factor, because we have specific risk factor as emergency physician. The reality is that we burn out faster than the general population because of specific risk factor. And what is the specific risk factor about us? Every emergency physician knows that we have difficult relationship with the patient because they are very anxious, very angry, we make night shift, we have a big emotional load workload. It's very, very hard for us to work in this condition. And there is a reality we denied. It is that we are exposed to post-traumatic stress disorder, and we are denied to this symptom and this reality. And the second is vicarious trauma. Vicarious trauma is when we work a long time, we are exposed again and again to dramatic situation. And when we are exposed to dramatic situation, we absorb like a sponge, and one time we are very saturated and we cannot absorb, so we begin in burnout. Yes, I have forgotten hero syndrome. Every emergency physician and me too we have hero syndrome. We want to save every people, and we forgot us. And we have imposter syndrome. We have every time doubt, and we say, everything is okay, even if we have make everything, okay? We balance in the two extreme, hero syndrome and imposter syndrome. So we have risk. The specific is not specific, it is the accumulation of everything, like obesity, diabetes, cancer, addiction, cardiovascular disease, depression, and accident after night shift sometimes because we are too tired. So when it is too much, too emotion, too exposure, we become exhausted, and after we feel distant, we feel patient, we lose meaning, and this is burnout. We have the obligation to know our symptom. We are denied our symptom, and also compassion fatigue. Do you imagine the impact on our family? Okay, sometimes separation, more conflict, more anxiety, more stress. And do you think it is hopeless? Is it hopeless? What do you think? No. No, I don't think it is hopeless, because I'm an eternal optimist person, so I think it isn't hopeless. So it is time for action yet, and what can we do to get well and better? It is very important that to have a balance between work and personal life. It is very, very important to decrease our stress and risk factors. There is very, very strong scientific evidence, and I have read the literature. There is a lot of systematic review to explain what we can do, okay? The conclusion is that there is 3 levels, okay? Individual level, collective level, organizational level, and team level. The most one is individual level. We have the obligation to make something to decrease our stress, like sport, mindfulness. I every time make self-hypnosis because it is important and it is my competence. You make peer support, very, very important peer support. You must have daily habit to decrease your stress. It is obligate. The second is organization. When you are exposed to dramatic situation, you are obliged to make defusing, debriefing, supervision, a supportive leadership, and we must change our culture, okay? The culture must be recognizing what you do, and the system must support us, each other. Okay. I will come back to our resource. What have we, some resource when we are ill? The family support is the most important for me, and the second is peer support. You know, occupational health, it's important, but sometimes we don't go to occupational health because we have anxious for the judgment. We have anxious to lose our job when we are ill. Psychologists, psychiatric, we are denied of our symptoms, so we don't want to go to psychologists. And peer support is the most important. Literature say the peer support is the most important in our job. In France, I am a director of a peer support program, and I have a team of 20 health caregiver. And when sometime call this line, it is free, anonymous, and his job is coaching his peer to say, oh, now you must stop, you must go to the psychologist, you must make something for you. If you need money, we have a social worker, and we try to give a little money. If it is in separation, we accompany him with a lawyer. I think it is important, because when my husband say me, now go to the psychologist, I say no. But when a peer say, go to the psychologist, I say okay, because I say he understands me. It's different, okay? And I think little action, big impact. In France now, in hospital, we make a lot of little action like salsa, cardio box, into hospital. Because when we finish our shift, we are tired to go to the sport room. So into hospital, we make activity like salsa, like cardio box, workshop to manage conflict with patient. And we have now a lot of hospitals try to have a quit room to make a little break, to make a little massage. Half an hour is sufficient, okay, to take a break and to have the mind more free. And of course, we must eat better, okay. So the goal is now to say that you must focus on what we can control. What can I control? The most important is that I must communicate better with the patient to have less conflict. You must do that for you, not for the patient first time, for you before. And you must learn some tool to stress management for you. I say sport, I say self-hypnosis, mindfulness. Me, for example, I make self-hypnosis, I make bicycle, I go for a walk in the nature. It's very important. Nature is very, very important. You are obliged to know your limit and knowing your symptom. If you don't want to see your symptom, you can't care. It's important you know to limit. And our emergency physician don't want to see the symptoms. They are in the need, unfortunately. You must have varied activity. I think it's very, very important to see all the other specialties, congress. You can make piano, for example, music. It's important. And sleep, very important, sleep. When you are tired, when you go home, don't make dishes, please. Go to sleep, okay? It's very important. It's not a problem, okay? It's not a problem. There is a tough work at home. Go to sleep. My husband, when I come and I was very angry, I said, go to sleep, okay? And eat well, of course. There is collective fight, you know, collective fight, and the collective fight is the role of society, emergency society, union, not alone to make this fight, okay? Individual fight, individual action, second level, collective fight, and change the culture of the team, okay? So my last message is, we are human, okay, not hero. Don't forget, we are not heroes, okay? And we need each other. It's very, very important. We need each other. Peer must support our peer. Last days I say mentora. I think it's very, very important to help young people, even if we want that there is a lot of emergency physicians in the future, okay? And take care of yourself, talk together, support together, and act together. It is my last message. Okay, thank you very much.
Thank you very much, Dr. Nazmiye. I said she's always respecting the expectation of the audience. She always finish her speech on time. Am I right, Jamal? Yes. And yeah, you teach us how to fly.
It's okay.
Yeah, it's okay. You teach us how to fly in your presentation. Okay. Do you have any question or comments? Please stay there. Any question or comments? We have time for question or comments.
Last slide. Okay. I try.
Talk with yourself. Keep down. Sleeping, eating well, sporting.
This one. Oh,
En son slide'ı çıkarabilir misiniz arkadaşlar?
heroes.
Yeah,
Aşağı
so
en son.
I just have a comment, okay? No discrepancy with your thought or no disrespect to your thought process. But as a woman, I'm saying
Can
it.
you speak slowly? I'm not very good English.
Okay.
Sorry. Come there. Please give a microphone to Nazmiye because
Yes,
there is an
yes.
audience problem.
Give me a microphone.
Give a microphone to him. Mobile microphone. Give her a mobile microphone. Okay. Yes, please.
Yes, it was amazing presentation, and it's one of the closest to my heart because I suffered with anxiety and I go to occupational health with the burnout. But with all due respect to you, we are human and we are heroes of our own life. So we need to be heroes and we need to have the insights for where we need to take an action. And then when we take an action, we are heroes. So don't try to be a hero. I don't agree. I want to be a hero of my own life. I don't agree of not being a hero.
I agree. We must be heroes, of course, but not sacrifice. Do you imagine? Not sacrifice our health. Because sometimes we work, we are exposed to a lot of traumatic situation, and sometimes we go home and never we go to the work. Okay, it's important to find the balance. Okay, not sacrifice. Okay, to be a hero. It's important because for our yes, it's important. I agree, but not sacrifice. Okay, and I'm sure every people here. Some often in her career are exposed to burnout. Me too. Okay, me too.
Okay, thank you very much. Yes, one more or two more. Yes, Jamal.
Slowly.
First of all, thank you very much, Dr. Nazmin. It's a topic that's also close to my heart, and I think a lot of us experience the same thing. I just want to ask, since you're a director of a peer group support, right? Do you do any validation psychometric tools or questionnaires that you pass on to the doctors so that you can assess them periodically over a period of time?
Can you please can you repeat,
in
Jamal, can you repeat your question again, please?
I'm just asking yeah.
Sorry. Okay, this program we're working with Canada. We have a partnership with Canada, and we work with program the French because they speak French. It is the program d'aide aux médecins du Québec program who help medical doctor in Quebec. Okay. It worked about 30 years. Do you imagine 30? We are too late. Okay. So after pandemic, France says, okay, we must make a program to help medical doctor. Okay, we're working together with Canada. Now we have training with the medical doctor who work in the program to learn how to repair suicide. Okay, and we have training with the Canada to have all the tools to accompany medical doctors who are in distress, okay? Score, yes, we have score. We have three score, 1, 2, 3. 1 is very urgent. Okay, we must call because there is a platform with email or with telephone. Okay, when they call, the peer had the obligation to call the patient, I say, okay, in 24 hour maximum, okay, to call. If they feel it is very dangerous, he feel perhaps suicide, okay, we activated 112. Okay, it's important for us.
Okay, one more question. Do you have?
There is developer in a lot of countries, Belgium, in Sweden, US, I think.
Okay, I will do a
There are
short.
few,
A question?
there are few validated burnout screening tools which are used across the world. But as she said, we are too late because especially in medical fraternity, we have picked up very late because we think we are heroes, as you said. So that's very true. When it comes to burnout, there are scales specifically made. And yes, we can tailor it according to our needs. But validation, as you said, we need to do a pilot trial to your own continent. If you're from Malaysia, you need to do it for your own continent because the burnout scale will be in a different style. Though the burnout timings and the periodical effects will be similar, but the work conditions will be different, environmental conditions will be different. So that would work in a different manner. But there are validated tools there.
Okay.
Thank you.
Thank you very much. Let me do a very small statement.
Thank you very much. Take care of us.
Wait, please wait. Now, just my question to audience. Is there anyone who have never been burned out in this classroom? Everybody? Jamal, you also? You too? Okay. You are funny, man. You are always smiling. Yes, burnout. You are much more clever than me, I believe that. But I have some experiences due to my age, Dr. Alvi. I just will give a suggestion to audience. The thing that we don't like and harms us, we can call it is burnout. The hardest burning out is coming from the closest friends. Even from your husband, from your wife, and from your darling. Yes, this is really very difficult to struggle with it. For example, I live in Turkey and Alvi, he lives in Malaysia. There is no any relation about the burnout between us. Because it doesn't mean Behçet is very nice. And he also a very good man. Can never cause a burnout, no. If you work closer to each other, because we are human beings, our feeling, thinking, and the expectation is always dynamic. They will change. So there is something you like it very much, but your friends hate it. In my life, I learned a philosophy approach. It is that if you can be able, for example, there is a problem. If you could be able to change it, don't stay change it. This is your mission, you have to do it. Because you are sitting in this side. For example, if you are a chief of emergency department, you don't have right to complain. The complaint is not your responsibility. Find the solution is your responsibility. You have to find the solution for the other people's. Next, you have problem and there is no solution. Please, don't struggle with yourself and others. Don't punish yourself and others. Because something is about systems. It's about system. You never can change it. If you want to make your life easy, the thing that you can change should be changed. Do not stay. Change it immediately. If not, don't punish yourself and another one else. So yes, burning out is a problem that we are facing every time, but sometimes it could become a teacher for us. We have many to learn from burning out. the first step that we have to is not to burn out anyone, to be chastised, yes, right? Yes, she's agreeing with me. This topic is a very common topic, and it is talking on it so much. If, for example, especially for residents, because we are mature people, doctors, but we have residents and students, and also discussing about this issue so much. If you think about something that harms you, you don't like, it harms you. If it is even difficult, if you try to see, yes, it is difficult, but I can benefit from it, it becomes a good thing for you. And it helps you. Dr. Jamal, agreement with me? And thank you very much for attending this section. And welcome, you are always. Our speakers, can you come here for a photo? Yes. Sama, Nazmiye, and Sevilay, please. Closing ceremony and presenting the gifts to the winners.
Time is coming. Dr. Sema, please. Dr. Sema.
Guys, please. Yeah, we want to start. Please go outside, please. Thank you very much. Yes, Sarah, please.
Okay. Welcome. Okay. Dear Chairman and dear listeners, welcome to the last day and last session of the Congress. In this presentation, I will talk about the sepsis new guidelines and biomarkers recommendation. Presentation plan will be like this, and yes, we know that the sepsis is still a life-threatening organ dysfunction, and early diagnosis is still the most critical factor determining the mortality. But we know that, again, clinical diagnosis is often delayed. So, dynamic biomarkers and risk stratification tools are coming to the forefront. In current guidelines, definition remains the same, but they recommended use of NIVS, NIVS2, MIVS, SIRS instead of quick SOFA, a single tool for sepsis screening. And there is insufficient evidence to make recommendation regarding the use of novel rapid host response diagnostic methods. This is important. Sepsis is a clinical diagnosis and should not be ruled out using a single biomarker of diagnosis test. This part is very surprised for me. The guidelines recommended for us using of like a sepsis code. In our country, we use blue code or stroke code, but this isn't, I think, new for me. They recommended use of like a sepsis code. And lactate dynamics. In previous guidelines, we know that lactate bigger than 2 millimole per liter was considered an indicator of hypoperfusion, and lactate clearance was targeted about resuscitation endpoint. We know that the lactate level can affect from anaerobic metabolism, but not just that. It can affect same time mitochondrial dysfunction, catecholamine effect, and trend dynamic change is more valuable than a single measurement. Which information remains? First of all, early lactate normalization provides information about mortality. Still, we know that. Serial measurement, a stronger predictor than single measurement, is important. But lactate have some limitations about liver failure, beta agonist use, seizures, exercise, and not sepsis cause. Another different sepsis cause can affect the level of lactate. Which information has changed and been added? And current approach, lactate is no longer the absolute target. So lactate level not show with alone about hypoperfusion. So clinical perfusion is most important than the single use of lactate. And the current guidelines recommended still use of lactate about sepsis, possible sepsis, probable or confirmed sepsis or septic shock. What is procalcitonin? Calcitonin is a precursor, procalcitonin is a calcitonin precursor and increased in bacterial infections, mostly suppressed in viral infections. And primary competency is about antibiotic management to date. And procalcitonin guided antibiotic uses is not considered about decision to start recommended alone. However, a powerful tool for discontinuation decision. In current guidelines, recommended the clinical assessment alone rather than clinical assessment in combination with procalcitonin. Clinical studies, current clinical studies show that procalcitonin-guided approach can decrease the antibiotic duration, can decrease resistant development, but mortality is not clear. Still, some studies is about neutral, some studies is decreased in some. Again, we know that procalcitonin have limitations, can affect from trauma, surgery, burns, and chronic inflammation again. I wanted to share for awareness the current guidelines for antibiotics. We still continue to take a blood culture as soon as possible. We should apply antimicrobial therapy within ideally 1 hour. And if the patients with possible sepsis who are not in shock, a time-limited rapid investigation can be considered within 3 hours. And future perspective, and about the future, the guidelines recommended maybe combined use lactate and procalcitonin may effective than use alone, and multi-biomarker panels, point-of-care biomarkers can be use a popularity. AI-powered early warning system, the main topics of all congress in all saloon. Thank you so much for listening to me.
Thank you, Dr. Serhat, for your speech. So, any question on the audio or any comment?
Is there any other conditions where lactate would go high, or it would be only sepsis where I can predict on lactate and say that lactate is high and the patient has got sepsis?
Especially, they recommended not only use of lactate level. They want to see, dynamic change about the lactate level. Maybe sometimes can affect the other situation, not anaerobic infections, trauma, burns, and others topics. But if the continue to measure that level, give an important information still.
Okay, thank you.
But
Thank you, Dr. Serhat.
thank you so much.
Yes, yes, please. And now second speaker is Dr. Cüneyt Arıkan. He will speak about antibiotic stewardships, short courses therapies for pneumonia and urinary tract infection.
Dear moderator and esteemed participants, I greet you all with respect. It's Cüneyt Arıkan. I work at Kocaeli University. And the final day of Congress, I will be sharing the recommendations of current guidelines regarding short course antibiotic regimens. Üçüncü sunum olacak arkadaşlar. İkinci ile üçüncü yer değiştirdik. The short course therapies for pneumonia and urinary tract infections. The presentation plans definition, advantages, drug classes, application principles, and patients suitable and unsuitable for treatment. First of all, what is the short course therapies? The shortest possible time necessary to effectively treat the infections. The traditional practice is 10 or 14 days of treatment. The perception is that longer antibiotic use provides a better cure. But the new guidelines say different things. Infectious Disease Society of America, it's a guideline, and the American Society, American Thoracic Society, and it's a guidelines. In Turkey, we use the same guidelines by pulmonologists and infectious disease specialists. Recommend its short course therapies, the new guidelines. Antibiotic for urinary tract infection, complicated urinary tract infection. Antibiotic course lasting 7 days or less. And pneumonia no less than a total of 5 days. If clinical stability achieved, no more is needed. And why short course therapies? First, the patient safety. because every additional day of antibiotic use increase the risk of side effects and associate antibiotic resistance. Each additional day increase 4% toxicity and 3% antibiotic resistance. And search optimization potentially reduce duration of hospitalization and lowers healthcare costs. And clinical efficacy studies confirm that a 7-day treatment course provides similar clinic cure and recurrence rates compared to 14 days. In complicated urinary tract infections, fluoroquinolones, it's recommended the use them for a total 5 or 7 days. Non-fluoroquinolone antibiotics, it's recommended the use them for a total of 7 days. And gram-negative bacteremia in patients with clinical improvement favor free course and hemodynamic stability. 7 days treatment is considered sufficient. The first day of administration of the effective antibiotics is the 0 day, and oral beta-lactams data on the efficacy of oral beta-lactams in the treatment uses are limited, but the recommendations is amoxicillin 1 gram every 8 hours and cephalexin 1 gram every 6 hours, the high-dose regimes. If the patient clinically improving, discontinuing antibiotic treatment on day 7 or earlier is high value in preventing side effects and resistance development. Also, which patients are suitable of short course antibiotic therapies? In patients who are receiving effective treatment and showing clinical improvement. What is the clinical response patients? Individual whose fever subsides and who became hemodynamical stable and whose symptoms improve. And acute pyelonephrit and bacteremia, and some patients who can switch from IV to oral treatment. But these regimes, some restrictions and groups consider because most of the evidence in the guidelines includes the patients with following characteristics. Generally, female patients, outpatient patients, and situations where the causative agents is susceptible to antibiotics. And which patients are unsuitable for short course antibiotic therapies for complicated urinary tract infection in high risk groups. And these groups, we usually 10 or 14 days regimes. First of all, male patients suspected acute bacterial prostatitis, urologic complications, for example, abscess, complete urinary obstruction, or recent surgery. Some medical comorbidities, immune-compromised patients, neutropenia, transplant, high-dose steroids, for example, and severe sepsis or septic shock, and device-associated urinary tract infections, nephrostomy tubes or urinary catheters, and pregnancy and lactation exclude this regime. The summary of the guidelines, clinical improvement is mandatory and search control is first. And pneumonia in outpatients and inpatients, adults with communicable-acute pneumonia who are improving, what is the appropriate duration of antibiotic treatments? The duration of therapy, the 5 days rule, no less than 5 days, but discontinue antibiotics only when the patients reach 5 days and meetings the stability metrics For example, resolving vital signs, heart rate, respiration rate, blood pressure, oxygen saturation, and temperature, ability to eat, and normal mentation. Adjunctive diagnostic tests in short course antibiotic therapy. In traditional cultures, results 48 hours or 72 hours, and risk inappropriate antibiotics therapy, selection for superinfection and Clostridium difficile infection. And the new recommendation is using a multiplex PCR, immediate target infection for unsuspected antibiotics resistance pathogen. If technology is available, send lower respiratory tract sample for multiplex PCR whenever non-standard severe pneumonia antibiotic considered. And adjunctive diagnostic tests in short course antibiotic therapy for pneumonia. The procalcitonin guide therapies, this therapy decreases the antibiotic duration mainly 2 and 3 days. And the results of short course antibiotics, some patient expectations, patients wants rapid symptom relief and prevent infection recurrence and removal IV access as soon as possible and discharge the hospital. The system objectives prevent dissemination of resistance organisms and mitigate drug side effects and cost and length stay of hospital. And this short course therapies shared solution, 7 days short-term therapies elevate patients' IV burden while serving system management goals. And final sentence of guidelines, right patients, right drugs, right duration, and thank you for your attention.
Thank you, Dr. Arıkan. So, any question or any comment on the auditorium? Thank you very much. Thank you. And the next speaker, latest speaker is Göksu Afacan. Is she here? Hangi sıralamada şey yapıyor? O zaman bekleyelim. Biraz bekleyelim. Then we will let another speaker a little bit wait. So she was in another speaking the other hall. So we will wait for coming for her.
sorguladığında, böyle karşılaştırdığında yani hekimlerin ön sezisinin çok daha kuvvetli olduğu, %90'larda falan orada VAS, diğerlerinde %86, 76 falan diye böyle skorlamalar var. Buradan ben arkadaşlarımıza, yani ben dün de konuştuk, orada oturumda da vardı, işte yapay zeka tehlikesini herkes konuşuyor filan. Kesinlikle ve kesinlikle hekimliğin hala ve ta işte hasta acil servise geldi, triyaj alanında hemen bir sandalyeye oturtuldu, araçlar götürdü, makineye bağladı, onun her yerini taradı. O noktaya gelinceye kadar yapay zekadan yani onları değil, onlardan ziyade hala biz asistanlarımızla, yanımızda çalışan daha junior hekim arkadaşlarımızla birebir hastaları muayene edip muayenenin çok ön planda ve çok klinik anamnezin, ayrıntılı anamnezin erken dönemde, daha çok erken dönemde, özellikle ayakta başlayan hasta popülasyonun olduğu noktada erken sepsis tanınması gerektiğini ve bu şekilde de mortalite, morbiditede çok büyük etkisi olacağını savunuyorum ve düşünüyorum da. Bu çok önemli olduğunu düşünüyorum. Diğer tabii ki ortaya bir şüphe atacağız. Değil mi? Ortaya bir taş atacağız kuyuya. O taşı da çıkarmaya çalışacağız. Kuyudan taşı çıkarmaya çalıştığımızda dediğiniz gibi o araçlar, işte prokasitonik kullanalım mı, şu kullanalım mı, CRP, CD, diğer şeyleri filan. İşte o noktada mantıklı, cost efektif bir şekilde değerlendirmek lazım. Her şeyde kesinlikle anamnez ve fizik muayene çok şüpheci olduğumuz noktalarda da prokasitonik kullanılabilir yani diye düşünüyorum. Çünkü çok kontrolsüz kullanılıyor. Kapıdan girdiği halde, yani ben şimdi özel sektördeyim. Yani SGK'ya iyi bir epikriz yazarak fatura edildikten sonra ödenmeyen bir şey yok. Ödeniyor yani, ama bunun için de devleti soymaya da gerek yok. Mantıklı hareket etmek lazım. Sonuçta dışarıdan aldığımız kitler bunlar diye düşünüyorum. Kesinlikle.
Duyamadım ama Behçet Hocam. Birkaç dakika bekleyelim çünkü doktor hanımın sunumu 11.05 bitiş gözüküyor. Yani bitirmek üzere olabilir. En azından onun bir 10 dakikası oldu. Tabii. Tabii. Bir de mesela bak, bu göğüs ağrısı kılavuzu yayınladılar geçtiğimiz yıl mesela ve orada tüm acilciler dahil oldu ve tüm kılavuzlara acilcileri soktukları an iş daha bizim açımızdan kolaylaşıyor. Ama burada bir eksiklik var Bedi Hanım dediği gibi. Yani o yönüyle de görmek lazım. Belki bunu da revize edip üzerine ekleyecekler. Mutlaka hani çünkü çalışan biziz. Bizim koşullarımız, mesela beni geçen hafta interneye aradı. Hocam acilden kan kültürü almasanız olur mu diyor koca hastane. Yani kan kültürlerinde kontaminasyon bilmem ne çıkıyormuş ya da istemedikleri. Hani biz böyle bir şeyle mücadele ederken biz de burada ilk gelir gelmez kan kültürü almayı, hemen bir saat içinde antibiyotik başlamayı düşündüğümüz hastalardan, bir taraftan hastanenin başka bir birimi ya kan kültürünü sen almasan da servis alsa bu kontaminasyonu engellemek için diye bunu düşünebilecek noktada olabiliyor. Hani o yüzden bizim koşullarımız, çalışma koşullarımız diğer klinisyenlere göre, diğer yatak servise göre daha farklı. Bence o yönünü düşünmek lazım diye düşünüyorum. O eleştiri bence haklı. Evet. Göksu Hanım hoş geldiniz. Yorucu bir gün sizin için oradan oraya. Çok yormuşlar sizi bu kongrede. Hazırsanız yavaş yavaş alalım sizi. Buyurun. Dinlenmek isterseniz dinlenin birkaç dakika. Bir de 17 Eylül Dünya Sepsis Günü arkadaşlar. Aklınızda olsun. Şimdi sizlerle de paylaşmış olayım. Sepsis Awareness Gün diye tüm dünyada kutlanan bir gün. Benim hatırladığım. Yapılıyor bir ton kampanya ama Behçet Hocam'ın dediği gibi maalesef mortalitesi çok yüksek. Hepimizi zaman zaman sıkıntıya koyan bir tablo. My friends, we continue our session. So next speaker, latest speaker is Dr. Göksu Afacan. She will speak about novel sepsis scoring systems. So yes, please, Dr. Göksu.
I'm so sorry for the delay. Good afternoon, my distinguished colleagues and friends. Thank you for joining me today. My name is Göksu Afacan, and I'm delighted to present novel sepsis scoring system, current approach from the emergency medicine perspective. Sepsis remain one of the most time-critical conditions we face in the emergency department, and improving how we recognize and risk stratify the truly some lives. Just look at the roadmap for today's talk. We will begin with the evolution of the sepsis definitions, review the strengths and limitations of traditional scoring system, then focus on the exciting the new developments, including the groundbreaking the phonics system, and novel adult tools and AI-based systems. Finally, we will discuss the practical application in the ER, limitations, and also the future directions. Just so sorry. Sepsis definitions have evolved significantly over the decades. In the SIRS era, we relied on infection plus at least 2 systemic inflammatory response criteria. While sensitive, this approach suffered from very low specificity because many non-infectious conditions could trigger the sepsis. The sepsis 3 definition in 2016, we marked a major shift. Sepsis is now recognized as a life-threatening organ dysfunction due to a dysregulated host response. So, operation as an acute increase in the SOFA score of 2 points or more. This evolution highlights why we need better scoring systems, and also especially the past-faced emergency department where early and accurate recognition is essential. Let's look at how the traditional scores compare. SIRS offers high sensitivity but very, very poor specificity. QSOFA is extremely simple and quick, using only 3 bedside parameters, yet it has a relatively low sensitivity and can miss the early cases. SOFA remains the gold standard for the assessing organ dysfunctions, but it takes time to calculate. NIVS-2, on the other hand, uses routine with vital signs and has demonstrated the superior performance to QSOFA as an early warning score in many studies. These tools laid the foundation, but their limitations have driven the development of the novel system. We will discuss it later. QSOFA is an attractive because its simplicity, asystolic blood pressure, non-respiratory rate, or the altered mental status. 2 or more points indicate the higher risk. However, NIVS-2 incorporates the more parameters, includes the oxygen saturation, supplemental oxygen use, making it more sensitive for the early detection. Multiple real-world studies have shown that the NIVS-2 outperforms to QSOFA in identifying patients at risk of deterioration in the emergency department. The takeaway is clear. While QSOFA is fast, but the NIVS-2 is a better screening tool in busy emergency department setting. In 2024, the Pediatric Sepsis Definition Task Force introduced a phonics criteria, the true revolution in the pediatrical sepsis. This NIVS score is based on 4 key organ systems: respiratory, cardiovascular, coagulation, and neurological. Sepsis is identified when a child with a suspected or confirmed infection has a phonic sepsis score of 2 or higher. Septic shock is defined as sepsis plus cardiovascular dysfunction. Why make it so special? Just because the research settings and shows significantly better performance than the old IPSS criteria. Here is the phonic sepsis score in detail. It ranges 0 to 13 points across the 4 organ domains. The respiratory component considers oxygenation ratios without support. Cardiovascular points include age-adjusted hypertension, lactate levels, and need vasoactive drugs. Coagulation and neurological domains at points for the thrombocytopenia, coagulopathy, and low Glasgow Coma score or fixed pupils. Importantly, this score can often be calculated even with incomplete data, making it practical. A score of higher than 2 identifies a children with potentially life-threatening organ dysfunction. The clinical impact is impressive. Children meeting the phonics criteria had markedly higher in hospital mortality in higher resource settings, and this score improves not only the clinical care but also the epidemiology and research in pediatric sepsis worldwide. It serves as an excellent model for how we can refine the scoring systems for adults also. Moving to the adults, several promising novel tools have emerged. The eSepsis aims to provide a simple, objective mortality risk score suitable for early use in the emergency department and hospital settings. We are also seeing refined versions of the SOFA and various hybrid scores that combine NIFS2 and QSOFA or IMEO markers such as lactate and procalcitonin. These developments focus on improving usability while maintaining the strong predictive performance in the real-world emergency department workflows. The most exciting frontier is artificial intelligence. The sepsis immune score by the Prognosis became the first FDA-authorized AI tool specifically for sepsis in 2024. Other machine learning models are achieving the AUC values and often outperforming the traditional scores. While these tools offer the real-time personalized risk assessment, they require the emergency human resource integration and continued validation. AI is not replacing the clinical judgment, but augmenting it significantly. And also this table is summarize the key difference. Traditional scores are easy to use but offer only moderate performance. The phonics score exists in pediatrics with high sensitivity and specificity. AI-based tools like immune score deliver excellent predictive power, while tools like eSepsis prioritize simplicity and emergency department applicability. Overall, a novel sepsis system provides a better balance between practically and also accuracy. So, how we should apply this in daily practice? A reasonable emergency department workflow starts with screening using NIFS2 or NIFS, followed by risk stratification with QSOFA or the phonics score in the children. In suspected cases, we add lactate measurement, also SOFA calculation, and when available, we can use the AI support. Of course, no scanning system is perfect. Limitations include patient heterogeneity, variable laboratory access in different settings, potential data bias in the AI models, and also the risk of the alert fatigue. We also need more perspective validation studies, particularly in diverse populations in regions like ours. These challenges also remind us to scares as aids, not replacements for sound clinical judgment. Then looking ahead, the future lies in the hybrid models intelligently combine the clinical assessment and also biomarkers and artificial intelligence. We can expect more real-time early warning systems and increasingly personalized approach to sepsis management. Updates to the Surviving Sepsis campaign guidelines will likely continue to emphasize these evolving tools. In conclusion, novel sepsis scoring systems such as the phonics score or eSepsis and AI tools like the sepsis immune score successfully address many limitations of the traditional systems. The central message for all of us in the emergency medicine is clear. Early recognition saves lives. I encourage everyone to stay updated with these developments and thoughtfully integrate with the most suitable tools in their clinical practice. Thank you very much for your attention. Please,
Afacan, so any question or any comment, my friends? Thank you very much for your speech. My friends, I am closing the session, so I wish you, I know that was a so successful Congress, I guess, so I wish you the next year, see you again here with your all health and everything is okay. Thank you very much.
temsilcilerimiz, 22. Ulusal Acil Tıp Kongresi, 13. Uluslararası Kritik Bakım ve Acil Tıp Kongresi, 13. Kıtalar Arası Acil Tıp Kongresi ve VACEM Liderler Zirvesi'nin sertifikasyon ve ödül törenine hoş geldiniz. Bugün burada tabii sadece bir kongreyi tamamlamıyoruz. Aynı zamanda bilgiyle, deneyimle ve dostlukla örülmüş çok özel bir yolculuğu da birlikte kutluyoruz. Günler boyunca bilimi konuştuk, paylaştık, tartıştık, öğrendik. Şimdi ise bu emeğin karşılığında onları birlikte alkışlama zamanı. Ödül törenimize başlıyoruz. Öncelikle saygıdeğer hocam Profesör Doktor Başar Cander'i sahneye davet ediyorum.
Evet. Her zaman kürsüden hitap etmeyi tercih ediyorum. Şimdi arkadaşlar, öncelikle hepinize sonsuz teşekkürler. Burada son dakikaya kadar bizimle birlikte olduğunuz için ve gerçekten çok yoğun olan 4 gün, ki bu 4 günün yoğunluğunu ben açılışta kısmen ya da tanıtım videolarında kısmen anlattım. Burada arkadaşlar şöyle gidip eve düşündüğümüzde şöyle bir şey var. Şimdi 5, 6, 7, 8 salonda belirlenmiş konular ve o belirlenmiş konular için kilometrelerce uzaklardan gelen ve yılların deneyimini kazanmış olan hocalar ve buna yapılan uzun hazırlıklar sonucunda bu bilgiyi bu kongrede sunuyorlar. Bunu böyle analiz ettiğimiz zaman arkadaşlar, buradaki harcanan emek ve enerjinin ne manaya geldiğini anlamak lazım. Şimdi mesela aslında derslere çok girmeyen bir arkadaşımız olsa dahi kongreden giderken kendini yorgun hissediyor. Neden biliyor musunuz? Çünkü ruhsal etkileşim var. Sürekli bilgi akıyor. Atmosferde bilgi var, yani bilim var. Ve bu üzerinize geliyor. Böyle bir bilim atmosferini birlikte oluşturmuş olduk. O yüzden hepinize çok teşekkür ediyorum. Çok gayret var, çok emek var. Mesela buradaki hocalarımızdan en başta Gökhan Hoca burada olduğu için söyleyeyim. Yılların profesörü olmuş, yıllarca hasta bakmış. Hepinizin şahsında söylüyorum, en solda olduğu gibi. Hepiniz böylesiniz. Ondan sonra bu deneyimi oluşturmuş, bir de gitmiş dersi hazırlamış, kilometrelerce yol gelmiş ve burada aktarıyor. Bunu 200 ile çarpacaksınız arkadaşlar. 250 ile çarpacaksınız. Burada böyle bir emek var. Bir de bunun üzerine bu katılımcılarımız bir yıl boyunca uğraşmışlar ve Atüder'in kongresine gelmeye gayret göstermişler ve bizimle olmuşlar. Dolayısıyla arkadaşlar bu kongredeki bu emekleri tekrar özellikle aramızda olan arkadaşlarımız adına tekrar kutluyorum, teşekkür ediyorum. Tabii kongrede değişikliklerimiz oldu. Biliyorsunuz açılış törenimiz oldukça renkli oluyor. Yine buna uygun bir tören yaptık beraberce. Üzerine arkadaşlar galada yeni bir çığır açtık. Ve gerçekten dünya listelerinde olan ve hatta o kuyrukların fotoğrafı duruyor değil mi? Ya ben diyorum ya arkadaşlar niye kuyruğa giriyorsunuz? Yer var şurada durun. Yok o kadar kuyruk oluşmuş ki. Neyse bize de malzeme oldu yani. Atüder'in gala gecesinin kuyruğu yani 100 metreyi geçti. Bu bizim için büyük bir onur. Tabii kolay değil bu işler. Bu işler kolay değil. O yüzden bu işlerde görev alan arkadaşlarımızı özellikle kutluyorum, teşekkür ediyorum. Burada ilk açılışta teşekkür edemediğim insanlar oldu. Onları da burada tekrar anıyoruz. Mesela hiç ayrılmadan çalışan Yusuf'u alkışlayalım. Menderes'e plaket verdik. Levent burada mı bilmiyorum. Levent'i de alkışlayalım. Levent burada. Ve psikolojisini çok iyi çözdüm ama çok çok zor günler geçirdi benimle birlikte. Her isteğimiz ona farklı bir stres yaşattı. Etiko'nun başında Adem Bey'in bu kongrede epey yüklendik. Tabii yanımızdan hiç ayrılmadılar. Yunus, Gizem ve Samet ve bütün ekip. Çok teşekkür ediyoruz. Hayatının kongresini yaşayan Rıdvan Bey. Rıdvan Bey, ses teknik ekibimiz ve bunlara çok teşekkür ediyoruz arkadaşlar. Burada olmanızdan çok mutluyum, çok gurur duyuyorum sizinle. Ve şimdi de biz Mine ile törene geçelim. Şeylere verelim. Onu da sizinle paylaşmak istiyorum. Biliyorsunuz ki biz gala gecesinde törenle başlıyoruz, ödül töreniyle. Ama bu blok 3 olmadığı zaman geçerliymiş. Yani blok 3 gelince biz böyle bir şey yapamıyormuşuz ödül töreni. Ancak ona ödül verebildik biliyorsunuz. Çünkü bitti, bitecek. 10 dakika, 15 dakika. Yani zamanın artık değiştiği bir sistem geldi karşımıza. Tabii saniyeler, hani Einstein'ın şeyi var ya, zaman relatif bir kavramdır. O anda nasıl geçiyor bilemiyorsunuz. Dolayısıyla arkadaşlar ödül töreni şimdi yapacağız. Birlikte ve biraz kısa tutacağız. Biraz formalitesini azaltacağız. Ama ödülü kazananlar her zaman o prestiji üzerlerinde taşıyacaklar. Merak etmeyin. Sadece törende biraz eksik olan yanı gala gecesinde yapamadık. Ya hangisini tercih ederdik? Bir yoklama yapalım. Blok 3 gelmesin, galada ödüller olsun mu? Yoksa blok 3 gelsin, ödüller burada mı olsun? Hangisi? Blok 3 diyenler? Ulan çok da yokmuş. İyi ki adam duymadı bunu. Yani blok 3 gelsin ama ödüller galada olmasın diyenler dedim. Ulan Serhat, sen anlamıyorsun herhalde. Niye kaldırmıyorsun? Peki. Tamam, teşekkür ederim. Geçiyoruz. Ama bunu kimse duymasın ha.
Evet, acil tıpçılar olarak bizler dinamik birer bilim insanı olmanın yanında aynı zamanda da ekip ruhuna sahip, rekabetin ve birlikte eğlenebilme sanatının da hakkını verebilen kişileriz. Bu yılki kongre futbol turnuvamızın dereceye girenlerini açıklıyorum şimdi. Üçüncülük ödülümüz Elazığ Fethi Sekin Şehir Hastanesi Acil Tıp Kliniği. Kendilerini sahneye davet ediyoruz.
Evet, Elazığ ekibini davet edelim. Ödülü vermek üzere yönetim kurulundan arkadaşları alalım. Ayhan Hocam buraya gelelim. Evet, Ayhan Hocam'ı alalım.
Tamam.
Pardon ya, bunların kupası yok mu üçüncülerin?
Yok hocam.
Üçüncüye
Sadece birinciye var.
Öyle mi? Tamam, peki. Pardon ya. Tamam.
Ben de yanınıza geçeyim hocam.
Evet. Çok tebrikler. Bu futbol yarışması üçüncü. İnşallah. Evet.
Ve futbol turnuvamızın ikincisi Pamukkale Üniversitesi Acil Tıp Kliniği.
Bora alalım. Bora. En güçlü ekip herhalde. Ekip burada.
Kalabalık.
Atakan Bey burada mı Atakan?
Atakan hocam mı?
Geliyor.
Yok, birinciye var hocam.
Tamam. Evet. Siz kupayı da hak ettiniz ama ne yapalım? Çok tebrik ederim. Bunun haberlerini yaparız. Çok tebrikler. Evet arkadaşlar, çok tebrik ediyoruz. Evet, gel Mert, gel.
futbol turnuvamızın şampiyonu. Atatürk Üniversitesi Acil Tıp Anabilim Dalı.
Zeynep hocam. Vay vay ekibe bak hadi. Hızlı nasıl diyor. Koşarak alıyoruz şampiyonu. Ne kadar yavaş geliyorlar.
Önce
Vay
sertifikamı
be.
söyledim.
Tebrik ederiz. Kaptan kim? Seni mi tebrik edeyim? Sen kupa vereceksin.
İkisini de hocam.
Evet.
Hocam birlikte isterseniz.
Kupayı. Poster verin.
Asistan bilgi yarışması var. Tüm takımlarımızı tebrik ediyoruz ve kongremizin en heyecanlı anlarından biriydi. Klinikler arası asistan bilgi yarışması. Bilginin, hızın ve ekip ruhunun ve ayrıca teknolojik altyapının mükemmel bir birleşimine sahne oldu. Dereceye giren ekiplerimizden 3. asistan bilgi yarışmamızın 3.'sü. Bezmi Team, Bezmi Alem Vakıf Üniversitesi Acil Tıp Kliniği.
Atakan, Halil Bey'i alalım. Halil hocam siz verin kupa ödülü. İkiniz mi varsınız?
Asistan bilgi yarışmamızın ikincisi 9. Senfoni 9 Eylül Üniversitesi Acil Tıp Kliniği. Kim geliyor hocam?
Ödülü kim ve Atakan hocam buyurun. Tabii. Tebrik ediyoruz. Tebrik ediyorum tekrar.
Ve asistan bilgi yarışmamızın birincisi Noktua Karabük Eğitim Araştırma Hastanesi Acil Tıp Kliniği.
Becet hocam ödül verelim. Vay be. Karabük damga vurdu yani bu sefer ha. Şey verelim, Becet hocam takdim etsin.
Behçet hocam. Önce sertifika sonra.
Bravo Karabük.
Şunu da hocam. Yine Behçet hocam.
Çok teşekkürler, tebrik ediyoruz. Başarılarınızı
Yarışma
devam
ekiplerimizi tebrik ediyoruz. Şimdi poster bildiri ödülleriyle devam ediyoruz. Bu alanda katkı sunan tüm katılımcılarımıza ayrıca teşekkür ediyoruz. Dereceye girenler, poster bildirilerinin 3.'sü. High Flow Nasal Oxygen Therapy in Acute Hypoxemic Respiratory Failure, Clinical Outcomes and Indications, Burcu Yormaz, Konya Selçuk Üniversitesi Göğüs Hastalıkları Kliniği. Burcu Yormaz.
Burcu Yolmaz burada mı? Konya'dan bir arkadaşımızı alalım buraya.
Konya'dan temsilen
Evet,
Demet hocamı.
Demet hocam gel. Ödülü vermek için Vaşa. Vaşa please come Vaşa. Vaşa. Come for the gift present. Şey ver.
Ha şey pardon.
Vaşa.
Poster bildiri ikincilik ödülü. The effect of the type and timing of medical treatment on mortality and length of hospital stay in traumatic and non-traumatic intracranial hemorrhages. Onur Bozdağ, Beyzmi Vakıf Üniversitesi Acil Tıp Kliniği.
Saş. Please come. Sen aldın ödülü ha? Aynı çalışma.
Başar hocam. Poster bildiri birincimiz. Attitudes of Emergency Healthcare Workers on Electric Vehicle Accidents. Şerife Özdinç, Sağlık Bilimleri Üniversitesi Afyonkarahisar Tıp Fakültesi Acil Tıp Kliniği.
Halit, please. Öyle kupayı alıp gitmek yok. Kapıda durun. Kupayı alıp nereye gidiyorsunuz? 2 dakikamız var. Böyle kupayı alıp gitmek yok. Erzurum ekibi mi? Öyle. Kupayı alıp gidiyoruz. Bekleyin bakalım. Düz.
Sırada sözlü bildirilerimiz var. Sözlü bildiri üçüncümüz 2 tane. İkisini birlikte sahneye davet edeceğim. İlki Hematologic Emergencies in the Emergency Department Prognostic Role of Physiological Scoring System. Berika Şener, Manisa Celal Bayar Üniversitesi Tıp Fakültesi Acil Tıp Kliniği. Üçüncümüz The Impact of the FAST Protocol on Computed Tomography Utilization and Clinical Outcomes in Patients with Suspected Abdominal Injury After Traffic Accidents. Buse Betül Küçükkaya Gündoğdu, Karabük Üniversitesi Tıp Fakültesi Acil Tıp Kliniği.
Ödül vermek üzere de Serhat hocamı alalım. Serhat hocam. Bahadır hocam 2 tane ödül
Berika
var.
Şener yok galiba hocam. Berika Şener adına birisi.
Manisa'dan kimse var mı arkadaşlar? O zaman Denizli. Denizli. Mehmet Ali. Denizli'den birine verelim. Denizli'de olsun oraya ulaştırsınlar.
Buse Betül
şeye
dedi.
ver diyecektim ama daha gelmedi. Bir gelsinler. Gel bekle. Manisa'nın ödülünü o zaman veremeyeceğiz herhalde. Öyle görünüyor. Manisa'nın ödülü kaldı. Bahadır'a mı vereceğiz? Olmaz ya. Manisa'dan kime? Aydın'dan birini gönderelim. Evet yani. Evet verelim hocam. Evet. Bahadır sen ver.
Hocam da çıkmışken şey verelim mi?
Evet.
Bahadır Hocam hazır buradayken sizi göndermeyelim. Uluslararası sekreteryada olduğunuz için size de bir ödülümüz vardı. Verememiştik ilk gün.
Açılışta biliyorsunuz sekreteriye plaket verdik. Bahadır Bey gelememişti. Onu da takdim edelim.
Onu da hocam size vereyim. Sözlü bildiri ikincisi. The effect of NSAID use on emergency department visits with decompensated heart failure. Kevser Simbil, İstanbul Medeniyet Üniversitesi Tıp Fakültesi Acil Tıp Kliniği.
Behçet hocam,
Kevser Simbil.
Behçet hocam ödülü siz verecektiniz ama ödülü Zeynep hocam siz veriyorsunuz ödülü. Pardon, unuttum. Zeynep hocam veriyor ödülü. Sen almadın değil mi? Evet. Gevşer, tamam. Ve son şeye geldik değil
Ve
mi?
son ödülümüz.
Son ödül.
Sözlü bildiri birincilik ödülü. Investigation of the prognostic value of the on-call score in clinical decision-making process for oncology patients presenting to the emergency department, Jülide Gürbüz, Bezmi Alem Vakıf Üniversitesi Tıp Fakültesi Acil Tıp Kliniği.
Jülide, o zaman ben vereyim ödülü de.
Tamam hocam.
Bitiriyoruz. Var mı? Şimdi arkadaşlar son olarak en çok bildiri yayınlayan 3 kliniğimiz var. En çok bildiri gönderen. Onları da burada ilan etmemiz gerekiyor. Ve teşekkür ediyoruz. Ve onları da en çok bildiri gönderen klinik olarak plaketlerini ulaştıracağız. Atatürk Üniversitesi Erzurum, Konya Şehir Hastanesi ikinci ve Pamukkale Üniversitesi. Hepinizi tebrik ediyorum. Katkılarınız bizim için çok önemli. Bunlar acil tıbbın gelişiminde verdiğiniz emekler arkadaşlar. Bunlar boşa gitmeyecektir. Ve biz bundan sonrası için beraber yürümeye devam edeceğiz. Şu şarkıyı çalın. Neyse. Devam. Evet. Hepinize iyi yolculuklar. Uğraştığınızı bize bildirin. Fotoğraf çekme şansımız var mı? İster misiniz? Vaktimiz var mı? Yoksa hemen gidelim. Hadi çekiyoruz. Fotoğraf çekip öyle gidiyoruz. Hadi buraya, sahneye. Toplu fotoğraf. Çökebilir. Sahne çöker mi?
Çökmez ya. Dün çok fazla
Ağırları
bir şey
almayalım. Gelin ya, şaka diyorum ya. Evet. Evet,
Hocam
buyurun,
dün ciddi
arkadaşlar.
bir ekipman kuruldu buraya,
arkadaşlar,
çökmedi. O yüzden çökmez.
Olur olur. Ulan bu çöker mi ya?
Ben
Çöker mi?
şunu kapatayım bir.
Samet çöker mi bu? Tamam canım.
Finally, I can see you crystal clear. Go ahead and